Thank you, Chairperson. If you take the diabetic population, the diabetic is a unique disease that its complications may manifest before the disease. That's why the diabetic is very important in controlling the risk factors. Now, if you take the guidelines of hypertension, the recommendation is to assess the risk of the patient before start managing them. This can be done by a scoring system that with the scoring system you can assess the risk. When you get the risk, you can categorize these people to very high risk, moderate and low risk population. But see the diabetic population. Diabetic patients with target organ damage falls into a very high risk category. And even diabetic patient with no organ damage falls into a high risk. So most of the diabetic population falls into a very high risk or high risk, except a few diabetics who are very low risk and young people. They will also fall into a high risk when they go on. And keeping that in mind, we should manage the diabetic patient's hypertension accordingly. You can see the classification of definitions of hypertension. I think it's familiar to you all optimal, normal, high normal, grade 1, grade 2, grade 3 hypertension. So this chart shows that even in the high normal blood pressure, if a diabetes mellitus patient without any organ damage falls into a moderate to high risk category. And if they have organ damage, they will fall into a very high risk category even with a high normal blood pressure. With the degree of blood pressure rises, this risk increases a lot. So there is no controversy for threshold of treatment. Threshold of treatment is if the blood pressure is more than 140 systole, in most of the cases, you have to start on treatment to reduce the blood pressure and the diastolic blood pressure more than 90. If the patient is more than 80 years old, then of course you can delay the treatment up to systolic up to 160. So my question is, the main topic of the today is blood pressure, how low you should go. That is also a very important aspect. To answer that question, I will take you all through a few studies in the literature. That is, one trial is an ACCORD trial. It is published long ago in the New England Journal of Medicine. And the ACCORD trial, the study question was, does therapeutic strategy targeting systolic blood pressure less than 120 reduces the cardiovascular events? And it is the 2x2 design trial. They actually checked the strict hyperglycemic control also. But I'll just concentrate on the blood pressure control. So there were two arms in the intensive blood pressure control and standard control. You can see all the patients were diabetic. And they are a bit high risk because their diabetes was not controlled. The HbA1c is 7.5 to 11. And the age limits were, most of them were more than 55. And the most grades of blood pressure were included in the study, and their renal functions were reasonably okay. And the pressures achieved with the intensive and the standard treatment you can see in this graph. The intensive treatment almost reached 120 or low. And the standard treatment patients were between 130 and 140. And the results shows there is no statistically significant difference between these two groups to reducing the cardiovascular events. And except the stroke, other events were statistically not significant. So they concluded the results provided no conclusive evidence that the intensive blood pressure control strategy reduces the rate of composite of major cardiovascular events in these patients. And the next study came recently, is a systolic blood pressure intervention trial. It's a SPRINT trial. The SPRINT trial Again, in the intensive treatment, a goal of 120 millimeter mercury or less is compared with the standard treatment of less than 140. But see the exclusion criteria. Diabetic population was excluded in this study. There was no diabetic patient involved in this study. And you can see most of the high-risk patients were excluded. So this patient group was a fairly low-risk patients. And the study studied the primary outcome of cardiovascular composite. And the result, they achieved very similar degrees of blood pressure control when you come like accord. That is the mean blood pressure of 121 in the intensive group and about 136 in the standard group. And the results were exactly opposite of accord. There was a significant reduction in the cardiovascular composite, almost 25% risk reduction in the intensively treated patient when you compare with the standard treatment. And number to treat to prevent the event is only 61, so it is very significant. So you can see here most of the primary outcome, myocardial infarction, cardiovascular death, all were reduced in this population. So it's a low-risk population where this trial was stopped early because due to the benefits, and the incidence of primary outcome, 25% lower in the intensive arm, and the all-cause mortality about 27%. So you can see two different contrast trials giving in a lower risk population, reducing the blood pressure to a very low levels where may benefit the patients as far as the cardiovascular is concerned. Still, it's very difficult to answer this question. So I will go to another trial which was actually done to compare two antihypertensive agents, that is ramipril and telmisartan. Is one of the famous trials, is on target trial. And again, the outcomes were very similar to any other cardiovascular outcome studies, CV death, MI stroke or hospitalization. And there were a large number of patients, almost 30,000 patients enrolled in this study. These patients were high risk. Again, the diabetic patients were included in this trial. And the trial, in this trial, there is about 11,000 patients who had diabetes. So it's a good platform to study because it's an outcome study and to see at the levels of blood pressure achieved and the cardiovascular outcome. It was a sub-analysis. This sub-analysis was actually published 1 month ago. The cardiovascular outcomes and achieved blood pressure in patients without diabetes, with and without diabetes at the high cardiovascular risk. So what are the parameters they analyzed in the analysis? Cardiovascular death, myocardial infarction, stroke, hospitalization for heart failure, and components of composite endpoints. So you can see the results. Results actually showed diabetic population had a little bit higher blood pressure levels than the non-diabetic population. And the population as far as systolic hypertension is concerned. And the diastolic blood pressures were almost very similar in both groups, the diabetics and non-diabetics. And this graph is very important to show if it comes. So, okay, I will describe. So, when you find the different levels of high blood pressure, that is, they categorize into 4 blood levels, that is less than 120 millimeters mercury, between 120 and 140 millimeters, 140 and 160 millimeters, and more than 160 millimeters. Now, if you take the more than 160 millimeter systolic blood pressure, the diabetics have the highest incidence of cardiovascular events. And the best cardiovascular outcome for diabetes was seen in 120 to 140 millimeter blood pressure range. And if you see the graph, unfortunately the graph is not there. The risk is a J-shaped curve. That is, as far as the systolic blood pressure is concerned, it's a J-shaped curve. The best outcome of diabetes, best outcome for the diabetic and non-diabetics were between 120 and 140. But when you get the diabetic population, the given blood pressure levels, their incidence of cardiovascular points were very high. That means cardiovascular incidence were very high in diabetic population for given blood pressure levels, given blood pressure levels in this population. So when you compare with the non-diabetic patients. And they also check whether between 130 and 140 of systolic blood pressure, is there any difference between the diabetic population and the non-diabetic population. When in this group, the non-diabetic population has the primary outcome, and the cardiovascular outcomes were almost good. But diabetics, the primary outcome and the cardiovascular outcome were very bad. So that means keeping the blood pressure even between 130 and 140, it can increase the cardiovascular incidence in diabetes. So we are between a very small window to control the blood pressure. So again, when you reduce the blood pressure to less than 120, the cardiovascular mortality rises sharply in diabetic patients. That is, the lower blood pressures, they have a high cardiovascular incidence. So as far as the diastolic blood pressures are concerned, again it shows a J-shaped curve. I cannot show those curves. And any blood pressure reduction less than 70 increases the cardiovascular incidence. So two meta-analyses concluded that overall benefit of lowering the blood pressure in patients with type 2 diabetes largely disappears when the systolic blood pressure lowered less than 130 by 80, except the continuing incremental benefit of stroke. Further recent analysis of ACCORD trial has shown that the reducing systolic blood pressure to less than 120 was associated with increased risk of major cardiovascular events. So what are the lower target recommended by the guidelines in diabetics? If it is 18 to 65 years, target to systolic blood pressure target to 130. If well tolerated, you can go up to 120, but don't go below 120. If the age between 65 and 80, the target to treat is about 130 to 140. Keep the blood pressure between 140. And if it is more than 80 years, again 130 to 140. The diastolic blood pressure should be kept between 70 and 80. So what the guideline says, antihypertensive drug treatment is recommended for people with diabetes when office blood pressure is more than 140 by 90. In people with diabetes receiving blood pressure lowering drugs, it is recommended to target systolic blood pressure 130 millimeter mercury, and if tolerated, go down up to 120. That's a class 1A recommendation. In all the people, older people, you keep the blood pressure 130 to 140. And to target the diastolic blood pressure less than 80. Since there is a little bit of time, I'll go back to my graphs. This is a J-shaped curve you get with the red lines are diabetics and the blue line is non-diabetic patients. You can see all the outcomes. For the given blood pressure levels, the diabetes have higher incidence of cardiovascular mortality or incidence when compared with the non-diabetic patients. But when you reduce the blood pressure less than 120, the curve sharply goes the other way. That's the cardiovascular mortality rises in diabetic population because that if you compare the non-diabetic population, the absolute numbers will be very higher in diabetic population with the incident. Conclusions were the blood pressure levels more than 160 to 190 are associated with the increased risk of cardiovascular outcome and death. Lower levels less than 120, 170 also associated with the increased cardiovascular outcome and death. Patients with diabetes have consistently higher risk over the whole blood pressure range, indicating that achieving optimal blood pressure control is most impactful in this group. These data favors guidelines taking lower blood pressure boundaries into consideration, in particular in diabetes. So in diabetic population, when you are treating hypertension, don't go below 120. But in a very healthy population, even if you go below 120, nothing going to happen much. But in diabetic population, they are already a high-risk group. You should keep the lower systolic target to 120 in a young population and 130 in an older population like more than 65-year-old. Thank you.
But there's a bit of a controversy between the Americans and the Europeans. They sort of have slightly different views on how low you should go. I mean, the Europeans
actually, the Americans have recommended to go, because Americans are recommended because of the sprint trial.
Yeah, they have just 130 over 80 for everything.
Who?
The Americans.
No, I thought the European have said 134 by 80. The Americans have the lower, their targets are lower than the European ones.
Ambulatory blood pressure. The guidelines on the Europeans are speaking on the
office blood
pressure. Now, if it is ambulatory blood pressure, 120 is correct. If it is office blood pressure, 130 is the blanket cutoff.
Yeah, you have to reduce about 5 to 10 millimeter mercury for the home blood pressure monitoring and the office blood pressure monitor. Those things, ambulatory blood pressure monitor and the home blood pressure monitor will be about 5 millimeters less than.
No, I think you have to just assume that ambulatory blood pressure and home blood pressure are roughly the same. And the office blood pressure is so the 130/80 was what they were. That's because they had just put 130/80 for just.
So it will be a home blood pressure will be about 120, 125. Yeah.
Any things doubts you want to clear up about the blood pressure? It was a very comprehensive and very clear lecture. We're really sorry once again about the glitches in the transmission. So I'd like to thank Dr. Santharaj for the talk.